Next, we will talk about laboratory studies for acute leukemia. For patients with blood disease, we'll do the complete blood count first. If the patient was highly suspected of leukemia, we should proceed with the MICM examination immediately to give diagnosis and prognosis. From the CBC, the white blood cells could be hyperleukocytic, more than 100,000 per microliter, or be hypoplastic leukemia, less than 1,000 per microliter. The anemia could be normocytic and normochromic. Platelets could be less than 60,000 per microliter. The immature cells could be seen or not. The bone marrow always contains leukemic blast cells. We will do the bone marrow aspiration for the morphology. The WHO has invoked an arbitrary threshold of 20% of marrow nucleated cells being blast cells to diagnose polyblastic AML, at least 20% blasts, while FAB at least 30%. If any blasts, even less than 20%, are found with a case of AML in which the cells have a translocation of chromosome 8 and 21 or other CBF inversions or translocations, AML is the diagnosis. The marrow of most AL is hepatocellular. A few is hypocellular. Even the best hematologist or hematopathologist cannot always distinguish ALL from AML by cellular morphology alone. We should use histochemical stains to confirm the specific granule content of a malignant cell line. Histochemical staining of blood and marrow aspirate films is an integral part of the FAB classification of leukemia. The most commonly used stains, including peroxidase, combined esterase, PAS, can be very helpful. Peroxidase stain detects myeloperoxidase enzyme contained in the primary granules of myeloid cells. In the presence of hydrogen peroxide, myeloperoxidase releases free oxygen that can be detected with the benzidine or 3-amino-9-ethyl-carbazole. The lighter reagent gives a reddish-brown reaction product, whereas the benzidine reagent products a bluish-black product. Myeloperoxidase is abundant in nearly all mature and immature myeloid cells, such as M2, M3, M4, and is also present in monocyte, M5 to a small extent. Combined esterase stain uses two substrates, alpha-naphtho acetate and naphtho-ASD chloroacetate, to distinguish myelocytes from monocytes. The chloroacetate esterase stain specific esterase identifies the primary and secondary granules in myeloid cells, M2, M3, M4. It gives a negative or very weak reaction in monocytes, M5. Furthermore, it is resistant to treatment with sodium fluoride. The alpha-naphtho acetate stain, non-specific esterase, produces a strong reaction in monocytes, which is positive to a lesser and varying degree in mature and immature myeloid cells. The monocyte reaction is inhibited by sodium fluoride, specific for M5. Periodic acid sheath PAS stain involves the oxidation of carbohydrates by periodic acid to aldehyde products. Mature myeloid cells stain intensely red. Myeloblasts are usually negative. The PAS stain is therefore useful in separating AML from ALL. Lymphoblasts can show heavy block-like staining. Marrow specimens should be collected for immunophenotyping studies by flow cytometry, the detection of immunological markers, cluster of differentiation CD. Each cell line has the same or different antigen conversion at different stages of differentiation. Some specific antigen can help us identify AML from ALL. For example, CD13 and CD15 can help distinguish AML from ALL, as well as specific subtypes. For example, CT41 and 42 only present on macrokaryocyte. HLDR present on AML and ALL, but not in APL. The EJAL proposed an immunological integral system, as shown in the table. Specific cell line with a specific CD has a specific score, to divide AL into 4 subtypes. First, acute undifferentiated leukemia, AUL. Myeloid not more than 2 scores, and lymphoid TOB not more than 2 scores. Second, mixed phenotype acute leukemia, MPAL. Myeloid more than 2 scores and lymphoid TOB more than 2 scores. Here we have 2 concepts. Bilineal patterns of antigen expression means 2 distinct populations of bloods that can be assigned to different lineages. Biphenotypic patterns of antigen expression means a single blood cell population that express antigens of more than 1 lineage on the same cell. Third, AL with myeloid means lymphoid TOB more than 2 scores and myeloid not more than 2 scores. AML with a lymphoid means myeloid more than 2 scores and lymphoid TOB not more than 2 scores. Fourth, acute leukemia of single lineage. Myeloid equal to 0 or lymphoid TOB equal to 0. The last 2 parts of MICM are cytogenetics and molecular genetics. More than a half of ALs show some cytogenetic abnormality by karyotype, FISH, or PCR. These occur in a non-random fashion and are known to have a prognostic significance. Chromosomal abnormalities including inversion, translocation, and etc. Next, let's take a look at some of the chromosome reports. From this picture, we can see that there are 46 chromosomes, XY, with the translocation of the short arm P to 1, which means region 2, band 1 of chromosome 9, and the long arm Q to 3, which means region 2, band 3 of chromosome 11. This picture shows that there are 46 chromosomes, XY, with the translocation of Q22 of chromosome 15 and the Q12 of chromosome 17. This is a FISH analysis, shows that red fluorescence of chromosome 15 and the green fluorescence of chromosome 17 are fused on 1 chromosome. This is a complicated analysis, shows that there are 45 chromosomes, missing 1 X, with the translocation of the Q22 of chromosome 8 and the Q22 of chromosome 21, and the deletion of Q12 and Q32 of chromosome 9. This shows that there are 47 chromosomes, trisomy of 8, inversion of P13 and Q22 of chromosome 16. Based on validated cytogenetics and molecular abnormalities, AML can be subdivided into 3 risk status: favorable, intermediate, and poor. For example, the translocation of 8 and 21 or inversion of 16, seen in 40% of M2, is associated with a better prognosis, while the TP53 is associated with the worst. In ALL, the genetic abnormalities can suggest ALL therapy and prognosis. For example, hypertriploidy, the presence of an increased number of chromosomes per cell, DNA index greater than 1.0 is more common in children sensitive to methotrexate. Approximately 3% of children and up to 25% of adults with BALL will have a translocation of chromosome 9 and 22, similar to the chromosome Philadelphia. The prognosis, which is very poor, and the treatment should contain TKI. MICM is used in addition to diagnosis. The residual malignant cells can be detected with all of these highly sensitive procedures, including immunophenotyping and haploid analysis, detection of furin gene transcripts, karyotyping. The other laboratory abnormalities that are associated with AL include elevated lactic dehydrogenase, LDH, and uric acid levels, and a variety of electrolyte abnormalities. Abnormal coagulation profile, for example, DIC, especially in M3. Cerebrospinal fluid examination should be done for the prevention and treatment of CNS infiltration. In the CNS leukemia, the fluid pressure and protein are high. Glucose is low. The leukemia cells can be seen. Thank you.